Sun Life Financial is proud to partner with Canadian HR Reporter on this roundtable. National pharmacare is a key federal government priority, and finding a model that works for all Canadians is what matters the most. At Sun Life, we support access to affordable medicines for everyone. Visit www.sunlife.ca/national pharmacare for more information.
The Canadian government is seriously considering the implementation of a national pharmacare program. But how exactly would it work? Which model would make the most sense? Who would be covered? What drugs would be included? Who would pay for it? And how would employers be affected? Looking to answer these questions and more, Canadian HR Reporter recently hosted a special roundtable sponsored by Sun Life that delved into national pharmacare, including lessons to be learned from similar programs, the potential impact on employer benefit plans, and challenges around costs and administration. In this video, the first of a three-part series, panelists talk about the healthcare models currently in place for Canada and lessons to be learned from Quebec's model, along with the benefits of a mixed model.
It's federally funded and governed by the Canada Health Act, but when you look at the delivery across the provinces, different provinces offer different levels of care. So the term universal healthcare is not necessarily universal for all Canadians. There are systems in place for all Canadians, for catastrophic, for senior, for low income, but they vary by province, and even the drugs that are covered by the province vary. So I think part of the universal discussion needs to be about bringing consistency for Canadians across provinces and across territories.
In the world of transparency and communication, there's also a new realization of how fragmented the models are, various provinces and at the federal level. And I think the latest number is like around 100 different plans exist, right? Various plans for different demographic in each provinces and territories.
One of the principles is differentiating between universal versus first payer or single payer. Is you can have universality potentially as a principle, and there's different mechanisms and options to achieve that universality. So Quebec has a mixed model, but it's mandated coverage. And I think if you talk to many of the residents of Quebec as well as the government, there is a preference for that type of model. There are some challenges with how it's been established and implemented around some of the costs of the co-pays, deductibles, which is part of that underinsured component of affordability. It's not just the uninsured, it's the underinsured. But as a general model, one of the benefits of Quebec is that it does have a very robust formulary. And I think it's really important that we take a principled approach to equitable access to medicines across the country and ensure that, if you have coverage today on the private side, you do not have a walkback of coverage if you're on a public plan. We should be looking at increasing access, not decreasing what's available to patients.
And there's good and bad, and it requires tons of coordination because it's a dual regime and it's co-administered to a certain extent between private and the RAMQ. But there are good things, like the list you mentioned, Justin. It is a very robust list that could become an inspiration for some type of pharmacare in the future, to have this mandatory minimum coverage across a region, a country, that provinces have to provide, and then private insurers, employers can decide if they want to meet that minimum requirement or if they want to go over that.
The downside, though, to it is that it is fragmented because it's a multi-payer model. Mm-hmm. And because of that, you've got higher admin costs, you've got, it's a bit regressive in the sense that more of the cost burden is borne by patients.
And employers.
Exactly.
Because the pricing is not the same for the private payers as it is for the public system, and that's a big problem.
Exactly. And I mean, compared to other countries around the world or even other provinces within Canada, that regressive system speaks against the model in Quebec. I think it comes down to the conversation that you guys have said is, what kind of principle do we want? Do we want everybody to be covered whatever the cost, or do we want everybody to be covered in a certain way? What are the trade-offs?
So stepping back a little, I think the first lesson is that if you want to create a pharmacare program that's universal, the do no harm principle is paramount. And I would say that Quebec, in the context of the late 90s, when they did that, their fiscal sustainability from a macro perspective, remember everyone that we had major deficits around the country. So that was a response to a lack of coverage, yes, but also a way to deliver a public service around pharmaceutical products, which would be also fiscally sustainable. And right now we have a mixed system, and it's really unique in the world. For you look at the rich OECD countries, we're really unique in terms of the presence of the private and public to deliver on the pharma side of care. So I think the Quebec experience is a demonstration of how you can build from what exists.
Having a mixed model makes a lot of sense because you're leveraging the expertise and the efficiencies in the private sector. But at the same point, we need to have the real conversation about where those gaps are and what kinds of solutions we can implement to address them, because I don't think status quo is an option. I think as Canadians and as industry stakeholders across healthcare, that we ought to be advancing solutions to ensure that no Canadian is left behind.